Hi, Gabby.
Morning, Emily. How are you?
God, I'm so sorry. I thought I had it and I did not. So I will have to verify after this.
All good. Okay, I am gonna make you a co-host. Um, Actually, I don't think that I think that if I think I have to make you host in order for you to have um
Polls.
the polls. So let me know if you have the once you're host and if you get the polls.
Do.
Okay,
Do you
perfect.
have, yeah, perfect. Do you have to let people in from the waiting room?
I have a like security thing on the waiting room for like all that Zoom bombing that used to happen, whatever we used to call that. Um, and so let me see if I can figure out how to undo that. Good morning, everybody, as you're joining. Thank you for being here. Emily and I are just working through a couple of quick things. Should I go to preferences? Um,
Because I can also, I can also very much just manually add them if that's kind of what you've been doing.
That's what I had been doing. And I think we can figure it out for future weeks, but trying to figure out, it used to be fairly easy for me to see how to um, change that security setting, and I'm forgetting right at this moment. Good morning, everybody. Um, hmm, I don't remember.
That's okay. I
We'll
just,
figure it out.
um, I just put in the screen sharing, so hopefully you can still take that, like you can still use your slides.
Perfect.
Okay.
Excellent. Excellent. I will start screen sharing in just a second. Now I'm bothered by not remembering how to change the privacy setting. Um, we'll have to revisit that. I just can't remember. Okay. All right. I'm gonna, good morning, everybody. I'm gonna, let's see, make sure that screen sharing is working okay here. Does that look good, Emily?
It does. Yeah, it's in the it's not fully in the presenter mode yet,
Yeah.
but I can see your PowerPoint. Okay, awesome.
I will screen share in just a second. We're just working on a couple things here. We're on an intern only day at in Med A.
Oh,
And so I'm grabbed sign out from the night intern. But the Med B seniors on his way in is going to cover our list for the next 10 minutes, in like 5 minutes. So hopefully everybody will be okay for the next 5 minutes while I'm signed in.
good morning, everyone. Thanks for coming. All right, Gabby, do you feel like we're at a good point to get going? You're muted.
How funny that I'm muted. Sorry about that. I did not realize.
That's okay. Is now good?
Good.
You want it?
Great. Let's do it.
Okay. Awesome. Thanks you guys so much for being here. My name is Emily Grossniklaus. I'm a hospitalist at the Seattle VA, currently at the Seattle VA. And I'm so excited because I'm taking over as the R1 curriculum director from Gaby Berger. So today is our first day. So I apologize in advance if the Zoom glitches. I'm learning. I'm an active learner. Today we get to hear from Gaby Berger, who we all know as being an awesome clinician educator who's currently on boards at UW. And she's going to give us a talk on tips and tricks for cross cover. So really well timed. Thank you so much, Gaby. We really appreciate you. I will mute myself and then I'll just kind of, if any questions are coming up in the chat, I'll give you a heads up about them.
Perfect. Great. Thanks, Emily. Good morning, everybody. Super excited to be with you this morning. And yes, I'm really excited that Emily is going to be taking over your R1 curriculum. You're in for a treat this year. I'm usually pretty good at monitoring the chat too, so I'll try and look, but Emily's going to help me out. We're going to try some Zoom polls this morning like we did last week with Andy Lutz. And as a quick reminder, these talks are really designed as like high yield applicable talks for the beginning of the year. So things that we know that you're going to be encountering in the hospital at the beginning of intern year. So today we're going to talk about managing cross cover. Okay. Cross cover is not the most glamorous topic in the world, but I will tell you it's probably one of the most important skills that you will hone during your intern year. And so we're going to try and focus on how to triage common cross cover calls, really focusing on practical skills for assessment and treatment. So we're going to cover 4 main topics today that come up really frequently when you're cross covering. So altered mental status, managing nausea, vomiting, managing constipation, and insomnia. Again, not the most glamorous, but hopefully super practical. Okay, so imagine this scenario. I don't know if any of you have been in this situation yet. It's 9 p.m. It's not 9 a.m. It's 9 p.m. and the pager goes off. And the page says something like this: "Doctor, your patient is altered." Okay, so we're going to get started with a case as we introduce our first topic. So you call the nurse back and you get some information about this patient. And he is a 65-year-old gentleman with COPD, cirrhosis, and AFib who's admitted for a new PE. He was started on a heparin GIP, nebs, and oxycodone, and he has IV morphine for breakthrough pain. But the nurse is calling you because he's holding evening meds because the patient is somnolent. And they're afraid he's not safe to take meds. Okay, so being the excellent intern that you are, the first thing you do is glance at your sign out. You see that this patient is listed as a watcher, and you look at labs from earlier today. What information do you already have? So here's some information. The sodium earlier today on the Chem 7 was a 127, BUN was 75, and creatinine was 2.1, and all of his other labs were normal. And you get some vitals from the nurse, and these are his current vital signs. So blood pressure of 100/60, he's a little bit tacky, he's breathing comfortably at 16, and he's 92% on 4 liters. Okay, so you go see the patient because, you know, as a good intern, you often need to get to the bedside and see what's going on. The cardiac exam is irregular, but no lower extremity edema. He has some scattered wheezes on his pulmonary exam, no crackles. But on his neuro exam, you note that he's somnolent. He is arousable to voice. He withdraws from pain symmetrically, and he does not have any clonus on your exam. Okay, so as the night intern, what is the best next step for evaluating or managing this patient? And we're going to launch a poll here. So do you want to give Narcan 0.4 milligrams IV times 1? Do you want a stat CTA of the head with a stroke protocol? CTA of the head and neck, I really should say. Do you want a stat Chem 7 and ABG? Are you going to start 2% saline at 30 cc's an hour, or start lactulose 30 grams POQ4? All right. Emily, can you see any answers coming in?
Yes, we are at 29 of 44. So people
All
are
right, keep coming in, everybody.
In progress.
Okay. So everybody put in your answer. Best choice, best guess. All right, and let's see where folks are.
Okay, here we go.
Cool. Okay, great. So everybody can see this, hopefully. So we've got about half of the group thinking that they want to stat Chem 7 with ABG. Some folks voting for Narcan, some go in for a stat CTA of the head, looking for underlying stroke, wanting to make sure that you're ruling out some of the can't miss etiologies. And then some folks really honing in on that low sodium from this morning, that sodium of 127, and thinking about hypertonic saline. Okay. So here is what I think is probably the best answer in this particular case. So about half of you got that answer, and we're going to go through why. But really in order to understand why, I think it's helpful to really talk about an approach to altered mental status. And I'm curious, people can just throw in the chat if they have an approach to altered mental status. Is there a mnemonic you use, some other approach, a way of organizing the differential? Misto, love it. Awesome. Okay, anybody else? See, Nicole, I know where you come from. And so I think I understand the Misto thing. Joanna, excited to see you know this as well. Some people hear about vindicates, go times, great. So there are lots of different, I think the point here is there's lots of different frameworks. No one framework is the right way to think about something. I'm going to introduce everybody to the concept of Misto today. This is the one that I've used for years. I find it easy to remember and helpful to organize. It doesn't have too many different components. But the point is choose something, choose a framework that works for you and stick with it so that you can be organized in your approach to this problem each and every time you see it. Then you won't miss things. And I'll just share actually that on the very first day when I was on service last week with my team, we went to see a patient, hadn't met her before, and she was acutely altered. And so my team we went through this differential to help us think about what might be going on and what workup to order. So when we think about Misto, M stands for metabolic and toxic. So all of those things that might cause a tox or metabolic encephalopathy, like hyponatremia, hypoglycemia, you might think about uremia in the right case, hepatic encephalopathy, med effects, alcohol or drugs, things like that. Okay, hypercalcemia would also fit in this category. Okay, so any tox or metabolic cause. I stands for infectious cause, so that could be sepsis, right? Or any other infection that might cause somebody to be altered. S stands for both stroke and seizure. T stands for trauma. And again, we're talking about folks in the hospital, right? We're talking about people who are on the floor, you're getting called to see on cross cover. And so when we talk about trauma, usually that's somebody in the hospital who's like fallen out of bed, tripped and fell while they were going to the bathroom, something like that, and may have hit their head, okay? And then lastly, O stands for oxygen. And so that reminds me to think of both hypoxia and hypercarbia as causes of altered mental status. Okay, so why do I think Misto is so helpful? Well, it's not only that it helps us categorize the different buckets that we should be thinking about in terms of the differential, but it really helps drive our workup in a way that can be very focused and directed towards the patient in front of us. So when I think about tox or metabolic causes, you want to order a Chem 7, make sure you have a calcium. You might think about a UTOX depending on what's going on with that patient, not always, but you might think about that. You might think about serum or urine osms, again, depending on what's going on with the patient to try and better understand their physiology. Importantly, you might go to the bedside and check for asterixis to see if they might have encephalopathy, whether it be hepatic or uremic. And then super important is just to review the meds that they've recently gotten over the last, few hours, 24 hours, and look at that electronic medical administration record. What have the nurses, what's ordered, but what's actually been given? Right? So it's helpful to look at your sign out, what's ordered, but you want to see what the nurses have actually given. And when you do most of these things, you've covered a huge number of things in that toxin metabolic category. If you're worried about infection, right, you're going to review the vital signs and think about your basic infectious workup in the hospital. As I talk about that, throw into the chat, what's your basic infectious workup for somebody in the hospital? So let's see what folks think. And, I think the thing that's really important, awesome, love it, good. Okay, great. So you're thinking, I'm seeing some diagnoses there, pneumonia, UTI, but the workup, absolutely. You want to get a CBC, a UA, a chest x-ray, and often blood cultures, right? So that's sort of our basic infectious workup. If they have ascites, you might want to get a paracentesis. There are other things you can do, but that basic workup is like a core skill, sort of skill, not even skill. It's like what you want to be able to, put into the Epic or into CPRS with your eyes closed, right? Note that I say you rarely need an LP. So remember that these are patients that you're being called to see as cross cover. Okay, so most people are not going to develop like acute bacterial meningitis or acute viral encephalitis in the hospital during the middle of their hospital course. It's possible. There may be situations in which you need an LP. Note that I don't say never get an LP. But when you're thinking about that common sort of infectious syndromes that we see in the hospital causing altered mental status, rarely are you going to need to get an LP. You might need to in the emergency room if you're admitting a patient for the first time. That's different than cross cover, right? So just want to start to have a framework for thinking about these things. Great. If you suspect meningitis, absolutely, Opti, then you're going to want to think about an LP, but that's probably going to be lower on your differential. Okay, stroke and seizures. Remember that your first pass is that non-con head CT, but remember that non-con head CT is just going to help you rule out blood and a major mass effect, right? So if you're really concerned, unless you're concerned for a hemorrhagic stroke, which maybe you are, but if you're really concerned for a stroke syndrome, you have to order a CTA of the head and neck. Okay, that's really going to rule out an embolic stroke. And remember, to really cause altered mental status from a stroke, you have to get both hemispheres or the reticular activating system. So again, stroke is usually not the first thing on the differential for altered mental status. It may be if you have a focal neurologic deficit, but not typically for altered mental status. Spot EEG may be helpful if you're concerned about subclinical status, and that's what our patient had last week when we were seeing her. She was actually having subclinical seizures, and so the spot EEG was helpful. And obviously, you're going to call neuro for assistance there if you're really worried about a stroke. Most of our hospitals, you can call a code stroke and get them there right away. If you're worried about trauma, like the patient fell out of bed and hit their head or tripped as they were trying to go to the bathroom, usually you just need a non-con head CT to rule out any bleeding. And then finally, if you're worried about hypoxia or hypoxemia, typically get an ABG or a chest x-ray. Now, every year I get the question, do we really need an ABG versus a VBG? Most times we get a VBG now. The traditional teaching is always that we get an ABG, but really a VBG is a pretty good proxy. It won't tell you about hypoxia, but it will tell you a rough estimate of acid-base status and of their CO2 or hypercarbia. Great. So I think MISTO is a really helpful framework because it both helps you with your differential, but helps you drive a focused workup. Okay, so coming back to our case, here we have the patient with a sodium of 128. So you get that stat chem 7 that you were thinking about. Sodium of 128, now his creatinine is 2.3, glucose 123. The ABG shows 7.2, 78, and 74 on 4 liters nasal cannula. You review the electronic medical administration record, basically looking at what has the patient gotten. He got morphine 4 milligrams IV at 6 p.m., which was about 3 or 4 hours ago. And so you correctly diagnose this patient as having hypercarbia. Okay, so you can see that elevated CO2 on the ABG. So throw into the chat, so why is this patient hypercarbic? This is the patient with COPD, Astrid, that's right. Yeah, exactly. Everybody. Yep, exactly. So this patient has underlying COPD, right? So they were already on, statting 92% on 4 liters at the beginning of this case, and then they got morphine. The important thing here is that remember that morphine is cleared renally. So in AKI, morphine can hang around longer. and so can cause more respiratory depression in somebody who has AKI, and then this person has underlying COPD with coming in with a COPD exacerbation. So all of those things together, which is commonly the kind of things that we see in the hospital. So this patient was transferred to the MICU for non-invasive positive pressure ventilation, also known as BiPAP. And the reason he was transferred to the MICU is because we cannot start new BiPAP on the floor. His morphine was switched to hydromorphone, also known as Dilaudid, which is cleared hepatically rather than renally. We'll talk more about that in a lecture later this summer. And everybody thinks that you are a fabulous intern. So great job. We are going to move on to case 2. Let me pause and see if there are questions about case 1 before we do that.
I actually have a quick question.
Yeah.
It's more about the framework of thinking about altered mental status. So I've always been very confused about like AMS versus delirium. And my understanding is that it's the same, but I feel like when you invoke one versus the other, it's a very different like impression, because I feel like delirium, a lot of times we say like, let's rule out misto stuff, but then also like, you know, like bowel movements, urination, hydration. So I don't know like what your approach is to thinking about those two different terms.
Thank you so much for bringing that up. I can't see who's speaking right now.
It's Joanna.
Oh, hey, Joanna, thank you. Whoever you are, Joanna, thank you so much for bringing that up. I think that by moving on to the next case, it might be helpful. So we're putting that a pin just in what you just said. Put it right there. So altered mental status case 2. 87-year-old woman who's been admitted for severe sepsis due to UTI. And she is treated with ceftriaxone awaiting SNF placement, skilled nursing facility, meaning she's been in the hospital, she's super stable, right? So now it's 9:15 and the nurse pages you asking for a sleeping pill. And so you call back to find out what's going on, and you find out that the patient, quote unquote, seems off. So what does that mean? All right, well, you get a current set of vitals, and here are her vitals, and they look pretty normal. But when you go see her, she's picking at her blankets, she's trying to sit up, and on your neuro exam, she thinks she's at home, she's yelling at somebody like maybe those little green men to get off the ceiling. And so what do you think is going on here? Throw it in the chat. And Joanna, it's almost like I planted your question, which I didn't, for the record, but it was amazing. Delirium, absolutely. So this patient is what we would consider to have hospital-acquired delirium or to be delirious, absolutely. Okay, so let's talk a little bit about delirium, okay? So the reason that I bring this up is twofold. One, for exactly the reason that Joanna just mentioned, there can be a lot of confusion about the difference between altered mental status and delirium, and it is unbelievably common in the hospital. I could show you data. I actually took the slide out because I feel like nobody needs to look at like data tables at 7 o'clock in the morning. But up to 1/3 of hospitalized patients on the acute care floor develop delirium during their hospital stay, and upwards of 60 to 80% of patients who have been ventilated in the ICU will develop delirium. Okay, so remember that delirium is a waxing and waning mental status, and you have to rule out all of the medical causes of altered mental status that we just discussed using the MISTO framework. You really want to convince yourself that none of those apply before you decide that somebody has delirium. Okay, delirium can be both hyperactive or hypoactive, meaning somebody can be very agitated, like this patient that we have in this case, or hypoactive, meaning they just kind of lay there in bed. They're not very responsive. Hypoactive delirium tends to be harder to diagnose than hyperactive delirium. But those visual hallucinations, seeing people in the room, super, 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 super typical of delirium. Okay. Auditory hallucinations do not happen typically in delirium, right? That makes you think more about a psychiatric diagnosis, but visual hallucinations are pretty common. Okay. The last thing I want to say before I share some of the things on this slide is that remember that altered mental status is a super bucket term and is very generic. It really doesn't tell you what's going on. So one of the things that can be really helpful is to try and characterize that altered mental status further. Is the patient confused? Is the patient lethargic? Is the patient agitated? Is the patient somnolent? Right? All of those adjectives are going to help you characterize the altered mental status, will also help drive your workup. Okay, so when you're thinking about delirium, you're absolutely right, Joanna. The important things are to sort of try and manage the underlying cause of the delirium. It might be infection, for example, but really these are the things that we see super commonly in the hospital. Pain can drive delirium, urinary retention, constipation, and so you can treat all of those things. You want to avoid opioids and sedating meds when somebody is having delirium. Those are other triggers that are quite common, especially in older folks, or especially in people who are quite ill. And then you really want to try and prevent the complications of delirium. And so in EPIC, and there are delirium order sets that you can order. And when you do that, it triggers a cascade of orders for the nurses to implement, which is awesome. You don't have to put in the individual orders here, but nurses will bring a bedside commode so that patients aren't walking as far to the bathroom by themselves. They'll get a safety mat. The nurses will kind of focus on sleep hygiene, trying to like raise the blinds during the day, close them at night. Simple things that actually make a huge difference. You as the physician can then think about removing unnecessary lines, tubes, and restraints, right? Those Foley's or other things that are tethering the patient to the bed. And then frequent reorientation. So if you have family at the bedside or other loved ones, that is oftentimes the most helpful thing. When delirium gets really severe in the hospital, there are a couple of medications you can use, okay? And so behavioral modification and changing the environment, that things I just went through, are the most important approaches to delirium. But as interns now, it's important to know what medications you have at your disposal if delirium is really severe. And you have two options. You have either haloperidol, good old Haldol, which can be given PO or IV, okay? And you have quetiapine or Seroquel, which is only available PO. Okay, we like to start with quetiapine or Seroquel if we can, but if you need something acutely, you need to give something IV. Haldol is really your only option for acute delirium. And that's really when somebody is quite agitated and is at risk of harming themselves or others. Okay, a couple of rules of thumb when you're using Haldol or Seroquel. Always remember you're going to start low and go slow, right? You want to just check at QTC, make sure it's not already prolonged. And by prolonged, I usually mean over 500. Okay. And I think people worry, we have learned a lot in recent years about the increased mortality risk of some of these antipsychotics in patients with dementia, but that's really in the setting of long-term use. If you need something, somebody is a danger to themselves or others, like your nursing staff, for example, in the hospital, it is okay to give a dose of these medications and reevaluate when the situation is calmer. Okay. Questions about that before I move on to the next slide? Joanna, does that help a little bit sort of separate out sort of the medical causes of altered mental status from delirium? Yeah, it's a great question.
Yeah.
Very important.
Thank you. And then I also just wanted to clarify, because I've also heard the term sundowning. Astrid had put it in the chat.
Yeah.
And sundowning is just like a colloquial term for delirium, I feel like. Is that correct?
Correct. It is a colloquial term for delirium that occurs in the evening. As the sun goes down, as nighttime falls, it is dusk. That is when people tend to get delirious. Not always, but that is super common. And that is why we're talking about this here, because people might be fine during the day. And then you're the cross-cover intern getting paged every night because this person is getting delirious in the evenings or at night. Okay. Awesome. Okay, so back to case 2, this 87-year-old woman who is awaiting placement at the SNF. You review that medical administration record, right? You think she's maybe delirious based on your exam, but you want to you go through Misto, sort of make sure you're not missing anything. And as you go through the criteria for Misto, you realize, okay, well, she is getting oxycodone 5 to 10 milligrams every 6 hours as needed. You also note that she's had low urine output. So you and the nurse do a PVR. And you realize she's retaining a lot of urine. So the nurse does an INO cash, she drains a liter, she feels so much better, and she promptly goes to sleep. And you, of course, are a super intern. So why is this patient retaining? Just based on the information you have here, there might be many reasons. I don't mean to make it that like simplistic, but a reason to think about and to be aware of is on this screen. Opiates, exactly. So reminder that opioids can cause urinary sphincter to have difficulty relaxing, right? So it can cause urinary retention, especially in older folks, especially who aren't necessarily on opioids at baseline. Awesome. Okay. So we're going to do a couple of quick takes here as we wrap up altered mental status. And this is the biggest section of our talk this morning. So this is a 78-year-old man with metastatic lung cancer who has been admitted for pain. You're called for a new onset seizure. The nurse tells you it started 5 minutes ago. He had a witnessed generalized tonic-clonic seizure while during med administration, lasted 60 seconds, and the patient is now unresponsive. His SATs dropped to 70s, but now are 90s on 2 liters. Okay, what's the best next step? We're going to do this quick. Just throw your ideas in the Zoom poll. Okay. Are you going to give lorazepam 2 mg IV now, do a phenytoin load, levetiracetam, which is also known as Keppra, 1 gram IV now? You're going to observe and order a brain MRI with contrast, or do a stat EBG. Are we good, Emily? What do you think? Oh, I think you're muted.
We're getting very close. 30, 31, 32.
Let's do it. Okay. We're going to keep things moving. Okay, excellent. This is why we ask these questions and do these talks, is to get us all on the same page, because there's quite a range of answers here. Okay, somebody chose every answer and there's not a plurality. So I think the correct answer here is to observe and order a brain MRI with contrast, and we'll talk about why. Okay. So the patient is post-ictal now, but protecting his airway. He's awaiting that MRI that you just ordered, but the nurse pages you again that the patient is having another generalized tonic-clonic seizure. Now, same answer choices. What do you do now? The second seizure in the evening, probably within a few hours. Okay, awesome. Okay, totally agree with you all. Most people chose lorazepam, and I would agree with you. In this case, I would choose lorazepam. Okay, so let's talk just really quickly about acute seizure management. Just a couple of quick pearls, okay? So for seizures that last 1 to 2 minutes and break spontaneously, like this patient, he seized and the seizure was done, and it was the first time observed seizure. In that case, you can observe the patient. But the reason we ordered an MRI is because we want to try and understand if there's a structural cause for that seizure, right? This is a patient with metastatic metastatic lung cancer, right? So he may have mets to the brain. And so you want to figure out what's going on in his brain. But he does not need medications in the acute setting, given this was a first-time seizure that broke on its own. However, for seizures that last greater than 1 to 2 minutes or are recurrent, if you're being called in the moment to break the seizure, we would typically give lorazepam. So Ativan 2 milligrams IV times 1. Okay. For ongoing seizures, the next step is usually Keppra, levetiracetam, or doing a phenytoin load. You're obviously going to be calling neuro at this time as well. But this is when you are being called to ask to write the orders for ongoing seizures. You're going to, if the patient has not been responding to Ativan, or if they're getting Ativan and continuing, you're worried about recurrent seizures, you're going to usually give Keppra or phenytoin. And most days we typically use Keppra these days. Okay. So our take-home points for altered mental status: use a framework to organize your differential and your workup. Okay. I like Misto. I think it's simple. It helps me not forget things and it helps drive a focused workup. If that doesn't work for you, use whatever does. Just make sure you have an organized approach. Treat delirium, thinking about delirium specifically, treat with environmental modifications, using your medications as a last resort, but know that they are available to you. And haloperidol and quetiapine, especially used ones, especially at low dose, are usually very safe. Okay, just check that QTC first. And then you want to use lorazepam for an active seizure and phenytoin or levetiracetam for recurrent seizures. All right. I'm going to move us on to our next topic. But if you have additional questions about altered mental status, please throw them in the chat and we'll make sure to come back to them at the end. Okay, great. Doctor, your patient is constipated. Everybody's favorite page. Okay, case 3. We have a 66-year-old man who's been admitted with left lower extremity cellulitis and volume overload. It's hospital day 4 for this person, and you're getting paged now. It's 11 p.m. for mild abdominal discomfort, and the nurse is concerned because he hasn't had a bowel movement since admission. However, you're down in the ER admitting another patient. So what do you do next? Are you going to order DocuSeat 200, BID, bisacodyl, PR, meaning a rectal suppository, Senna, 17 milligrams at night, tap water enema, or you're going to call the nurse and get more information? All right, what do we have? Oh, I love it. Okay, you are all such well-intentioned interns. I love that you want to get more information. I might surprise you by telling you that I don't think that's the right answer in this case. In this case, I think you have a couple of options. I think you could either do, and I'm not trying to, I know it's like when you have a multiple choice question, somebody's giving you 2 answers that are correct. I really just want to highlight that there are many different ways to approach this problem. And in this case, I think it would be totally appropriate to order a bisacodyl suppository or give this patient a tap water enema if they're open to it. Why do I say that? So the key teaching point here is, what is the minimum amount of information you need by phone to evaluate constipation? Okay, you are all really busy interns now. And I don't know if any of you have had this experience. Maybe your last night looked something like this. But when you're on nights and you're cross cover and you're getting paged all the time, it is really hard to stay on top of everything. And so it's all about triage, right? What do you need to deal with in what order? Which patients do you need to see and why? And what things can you triage over the phone? Okay, so let's talk about constipation really quickly. So when I think about getting paged about constipation and whether or not I need to be worried about that, I'm asking myself, is this a symptom of a more serious condition? And just ask yourself that. Is constipation usually a symptom of a more serious condition? The answer is usually not. Not never, it could be, right? But usually not. So what are you going to do to help you figure that out? So you're going to find out if the patient has a new fever, have had any vital sign changes, right? And whether they have any risk factors for obstruction. If you're concerned that this constipation represents obstruction, that's concerning. That needs to be managed in person and actively, right? But if you're not concerned and the nurse isn't concerned about obstruction, it's usually okay to treat these patients empirically. And then you just have to ask yourself, do you want to start from above or start from below, right? And the answer there is, how quickly do you want action? How quickly do you want that patient to poop, right? I'm going to give you like a quick framework for thinking about all the different things you can use to treat constipation. So you can either treat it slowly, treat it kind of moderately fast, meaning the patient will probably have a bowel movement within 24 hours, or you can treat it fast and make that patient poop now. Okay. So things that work slowly, like Metamucil, psyllium, stool softeners like Docusate, those work slowly. I never prescribe that stuff in the hospital unless a patient is specifically asking for it. Okay. A reminder that Docusate, there was actually a number of studies done a few years ago that show it's really no better than placebo. So in general, I don't use Docusate at all. Okay. When I think about treating constipation in the hospital, I'm usually in these two categories. I want somebody to have a bowel movement soonish in the next day or really soon because they're quite uncomfortable. So for moderately acting agents, you're going to think about polyethylene glycol. Polyethylene glycol is formulated either as Miralax or Go Lightly. Same thing, just formulated differently. Okay. Lactulose is also something that will work very quickly, usually within hours. So maybe I should put it in the fast category, but depending on how much you give. And those are osmotic, so they pull fluid in and make people poop. Okay. Senna and bisacodyl are stimulants, and so they also make people poop, usually within 24 hours. If you want to make somebody poop sooner than that, give them something rectally, right? So either bisacodyl suppository, glycerin suppository, and enema, or if you want to go from above, you can give magnesium citrate, which is a very powerful laxative and will make people poop within hours typically. Okay, so many options at your disposal. Decide how quickly you want somebody to poop and go for it based on that. And remember, we're almost never using any of these slow acting agents in the hospital. Ah, thanks, Connor. I didn't know that we don't have access to mag citrate in the hospital. So I would say use other things. The good thing about constipation is there's lots of things that we have available, but they may have to go with lactulose instead, which is kind of a bummer. It's like that doesn't taste good. Okay, so basic framework for thinking about treating constipation, right? Let's talk about advanced topics in constipation, which I realize is not something we always talk about, but it does happen. So this is a 38-year-old man with a sickle cell disease who's admitted for a vaso-occlusive crisis. He's using a PCA, which is patient-controlled analgesia, meaning he's on high-dose opioids, and he has scheduled Senna and bisacodyl to help him have a bowel movement. It's now hospital day 6. He's having new abdominal discomfort and constipation, no improvement with his typical treatments or a tap water enema. So now you're thinking, gosh, this is somebody I might want to get more information about because this isn't typical and his typical regimen isn't working. So you decide to get a KUB, and this is what you see. Throw into the chat what you think might be going on for this patient. What does this KUB show? Yeah, dilation, distension, great. So this is pretty common KUB for an ileus. So great question about SBO. We don't see any air fluid levels, so less likely to be an SBO, just a lot of gas, lots and lots and lots of gas, right? So this is an ileus. So for this patient, what's the best next step? He hasn't responded to typical constipation treatments. Are you going to give a dose of methyl naltrexone, naloxone, place an NG tube and do a Go Lightly drip through the NG tube, or gastrographin enema? And I think I changed that. Actually, I should have said lactulose enema. We're not using gastrographin very much anymore, but we do use lactulose enemas. So what would you do for this patient? Okay, let's see what we've got. Interesting. So again, a split, which I think is why we do these questions, so we can all learn together. Great. Okay, so I think that the answer I think is best in this case is methyl naltrexone. And I'll tell you why. I want to just give you a heads up quickly about options for really bad constipation that we can see in the hospital not responding to typical treatments. So I'm going to give you 3 options here: methyl naltrexone, polyethylene glycol or Go Lightly drip, and the lactulose enema. And I'm sorry, I had put gastrografin, but we're really using more lactulose enemas. So methyl naltrexone is an awesome medication that we use specifically for people who we think have opioid-induced ileus. So we have a patient on my service right now who we think has opioid-induced ileus who gets methyl naltrexone. It is an opioid antagonist, but it doesn't cross the blood-brain barrier. So it sort of counteracts the effects of the opioid on the bowel, promotes a bowel movement without precipitating withdrawal. We don't end up using this very often, but for folks who have cancer, malignancy in the hospital and are super high dose opioids because of cancer pain, sickle cell disease is another common one. Anybody who's on really high dose opioids or having opioid induced ileus or constipation, methyl naltrexone can be very effective. The Go Lightly drip you will see on occasion. Just remember that what you're doing with that Go Lightly drip is really if you think that there's something in the small bowel that you're trying to sort of dissolve. And so typically at UW, that'll be patients with cystic fibrosis, for example, who have inspissated stool in the small bowel, and that's what's causing their obstruction. Otherwise, typically you can just let people drink the Go Lightly instead of having to do it through an NG tube. The lactulose enema can be super helpful if you want to go from below or you think somebody's impacted. People do not have to have cirrhosis or hepatic encephalopathy to get a lactulose enema. The only thing about that is it's typically kind of a large volume of fluid, so it can be a little uncomfortable, but it's very effective. Okay, so just want to give you a couple of other advanced tools to put in your tool belt for really bad constipation in the hospital. So here's our take-home points for constipation. You do not need to do a bedside eval for every patient with constipation. You do want to try and figure out if there's something that you think is underlying that would make you concerned. Those are patients you want to evaluate, but oftentimes you can prescribe empirically without seeing the patient, and you want to choose a therapy based on how quickly you want results. Okay. All right. Any last questions about constipation before we move on?
I just wanted to make a comment / plug. Working with our nurses and pharmacists were super helpful because they understood a lot of the details about administering some of the enemas that we tried on this patient who couldn't get the mag citrate. And so I just learned a lot from talking to those 2 other team members because I felt very, I guess, unknowledgeable myself. And so they were great resources.
Awesome. Thank you so much for that, Connor. Such a great plug to always use our multidisciplinary teams. Okay. So now, doctor, your patient is nauseated. So you're on your 27th page of the night, and your patient is vomiting. So here's our next to last case. This is a 51-year-old man with pancreatitis who was admitted 3 days ago to the MICU, treated with IV fluids and bowel rest, transferred to the floor today, and he's still NPO. Vital signs are stable, but he's quite nauseated. So what do you do next? You're going to evaluate the patient, prescribe ondansetron 8 milligrams PO, finish that admission that you're working on in the ED, do an ondansetron IV, Q8, PRN, lorazepam, or find a bathroom because you just can't deal with this anymore. Hide. All right. Love it. Again, a little bit of a spread. And so I'm going to go with the majority on this one. I think that for this patient, it's probably okay to prescribe ondansetron 8 milligrams IV Q8 PRN. Okay. That is assuming the patient doesn't already have that on their med list. Okay. And I think the key here is that lots of things happen in the transfer process. And so things can fall off without realizing it. Meds can fall off. Okay, so here's the concept that I want to introduce with this case, and that is something that I fondly refer to as the emesis ladder. Why? I don't know. It's just like a stepwise approach to treating nausea in the hospital. Okay, so your first go-to is almost always going to be ondansetron, and the dose typically in the hospital is 8 milligrams IV Q8. Okay, people coming from different institutions, there are different ways of dosing ondansetron. This is our typical dose that we use at UW, and so that's why I provide that for you here. 8 milligrams IV Q8. If that's not working, your next step is typically metoclopramide, also known as Reglan, 5 to 10 milligrams IV Q6. If that is not working, your typical next choice is prochlorperazine, 5 to 10 milligrams IV Q6. Prochlorperazine is also known as compazine. Okay, and if all of those things are not working, typical next choice is going to be Phenergan or promethazine, which is given 6.25 to 25 milligrams, either PO or PR, meaning rectally. There's a rectal suppository for Phenergan or promethazine, I'm sorry, and that can be given Q6. And yes, all the slides will be posted. If you look at your ITC emails that you get, every week we'll include the link for the website. Okay, so why this order and why do we have IV for all the other meds here, but for promethazine, we say PO or PR. The reason is we try and avoid IV promethazine if possible. If a patient is asking for IV Phenergan, your spidey sense red flag should go up because that is not normal. I mean, it is normal, people ask for it, but people like it because it gives you a high. Okay, so if a patient is asking for IV Phenergan, should really sort of like pause and think about that request. Okay, you'll note that the reason we tend to go in this order is there's an increasing risk of side effects from your from the medications the further up you go on the ladder. So you want to start with ondansetron, fewest side effects. Promethazine tends to have the most side effects. Okay. So why is that? Remember that ondansetron or Zofran is antiserotonergic. The main side effect is that it can cause QTC prolongation. So that's something you might want to watch. But it's typically okay and doesn't have a lot of negative side effects. Metoclopramide and prochlorperazine, so Reglan and compazine, are both antidopaminergic. And so that's what you learned in med school about dystonic reactions, like a tardive dyskinesia, for example. And that we need to treat with IV Benadryl. It's rare, but it does happen. And so that's why we would start with ondansetron before these two others. And then diphenhydramine, also known as Benadryl, and promethazine, also known as Phenergan, these are antihistamines, okay? And notice that I did not even include diphenhydramine or Benadryl on the emesis ladder, right? That is not a medication that we should typically be using for nausea. And when patients ask for it, they sometimes do. It's not an absolute no, right? But you really need to pause and talk to your senior, talk to your attending, talk to your consultants. Why are they asking for that? So the antihistaminergic medications, when you give them IV, can cause a high. And that's why patients tend to like them. Okay. They're very sedating also. So again, it's not an absolute no-go. And there are situations in which it's okay to use these medications. You just want to pause and ask yourself if that's what they really need. Okay. All right. So oftentimes it is okay, again, to treat nausea without seeing the patient if they just need escalation of their therapies, but not always. Right. So here's a case of an 84-year-old who's admitted for community-acquired pneumonia. She has an extensive past medical history of hypertension, hyperlipidemia, diabetes, and a stroke. You'll notice all of this when you look at your sign out. Overnight, she develops new onset nausea and vomiting. She's afebrile when the nurse pages you. Blood pressure is 90/54. Heart rate is 108. She's satting 95% on room air. You decide that based on those vital signs, something seems a little off. So this doesn't seem like typical nausea to you. So you decide you're going to go evaluate this patient appropriately. And when you see her, she's oriented, but she's complaining of a lot of epigastric discomfort. So when you see her, she's also tired appearing, she's mildly diaphoretic, you repeat vital signs, and this is what you get. Blood pressure is 88/54, heart rate of 108. She's still statting okay, but she's on 2 liters. So being the astute intern that you are, you think, this just doesn't sound right. This patient looks a little bit sick. And so you get an EKG. And what do you see on the EKG? And throw them things in the chat. What are you concerned about based on this EKG?
Majority of it.
STEMI, that's exactly right. It's really concerning. ST elevations with tombstoning in 2-3 and AVF with reciprocal T-wave inversions, right? That's scary. So the point of this case is to say, when do you need to evaluate somebody in person? I am not saying that every time you get a phone call for nausea, that you should just say, oh, I'm just going to escalate therapy, right? You want to think critically about that and to have a framework, again, like Misto for altered mental status. What is the framework for thinking about nausea in the hospital? Number one, do they have, is this nausea atypical angina? Are they at risk for an MI? So you might think about coronary artery disease risk factors. Is this an atypical presentation? Right? That's what's happening for this patient, this older female patient in the hospital who has vital sign changes associated with her nausea. That's something that you should probably go see at the bedside. Are you worried about something going on in the CNS, right? With their nausea, is the patient having mental status changes, any new headache or blurry vision? That would make you think about increased intracranial pressure causing the nausea. That needs to be treated differently, evaluated and treated. And then finally, are you concerned about some scary ongoing GI process? Are they having coffee ground emesis with that nausea? Are they having hematemesis? Do they have new onset abdominal pain with the nausea? Those are reasons that you would go to the bedside to really evaluate that person. Okay. So in this case, you decide based on that EKG to call your senior and activate the STEMI pager. Patient goes for emergent PCI and is transferred to the CCU. And of course, everyone thinks that you're the best intern ever for picking up on that STEMI based on the patient's presenting concern of nausea. Okay. So our take-home points for thinking about nausea in the hospital. I don't think you need to do a bedside evaluation for every patient with nausea. However, ask yourself whether or not there might be the possibility of a more severe illness like MI or CNS disease or GI bleed. And if you're concerned, those are patients that you would want to see. Okay. And remember that you have that step ladder for thinking about meds to treat nausea, but you really want to avoid IV Benadryl, diphenhydramine, and IV Phenergan, which is promethazine. Awesome. Okay, we're going to close out the morning with a few last slides about insomnia in the hospital. Doctor, your patient can't sleep. Okay, points for everyone, anyone who gets their reference here. Okay, so our last case of the day, of the morning, it's now 2 a.m. You're getting your 67th page of the night. You have a 49-year-old man with left lower extremity cellulitis, and he has a history of anxiety and depression, and he's requesting his home zolpidem or Ambien 10 milligrams to help him sleep. So what are you going to do? You're going to order trazodone, 25 milligrams, diphenhydramine or Benadryl, 25 milligrams orally, temazepam, 15 milligrams, zolpidem, or go evaluate the patient. All right, our last case of the morning. What does everybody think? I totally agree with y'all. You could either order trazodone or you could order zolpidem. So I think either of those are appropriate options in this situation. So let me tell you why I think so. Remember that this is his home medication, okay? So approaching insomnia in the hospital, first you want to deal with the environmental factors, just like we do with delirium. Make sure that that patient is not watching TV at night. Try and discontinue vital signs overnight, and not by discontinue, just retime your vital signs. If a patient gets admitted at 2 a.m, then their vital sign checks, which we usually do every 8 hours or every 4 hours, depending, will default to 2 o'clock in the morning. There's no reason a patient needs to be woken up. Most patients need to be woken up for a vital sign check at 2 a.m, right? So retime those to do at 10 p.m. and 6 a.m. so the patient can actually sleep overnight. Don't give Lasix at 10 p.m. unless it's like emergent, right? Schedule your diuresis for earlier in the day. Don't make somebody stay up all night peeing. Ask yourself if there's a concern for delirium. And if you think there is, then you need to go back to our delirium evaluation and management that we talked about earlier. But if you're not worried about delirium, you've addressed these environmental factors, and people can't sleep because the hospital is a crappy place to sleep, and this is a chronic problem, it is okay to order people's home medications, okay? So things that you can use in the hospital, everybody I think is familiar with melatonin at this point. That's a great thing to use. Trazodone, very safe to use short-term in the hospital at low doses. It is really important to avoid benzos and diphenhydramine, Benadryl, especially in elderly people. Okay, note that Ambien or Zolpidem is not on here. We would typically not prescribe that for people who are not already on Ambien. If they're already on Ambien at home, it is okay to use it. If they are not on Ambien, we would try other things. Remember that Ambien can have a lot of paradoxical reactions, night walking, sleep terrors, etc. So it is actually not a great medication. It's okay though if people are on it at home. All right. So when you're treating sleeplessness in the hospital, I typically reach for Trazodone, 25 to 50 milligrams, and that can be quite useful. Avoiding Zolpidem unless the patient takes it at home, and just remembering to reschedule all those meds and vital signs during the day. I would say that's probably 80% of the things that we need to do for folks in the hospital. Okay. Thank you all for sticking with me this morning. Here are our conclusions. You are all super interns. I hope that in the future you use a framework for thinking about altered mental status for folks who are in the hospital when you're called on cross cover. Constipation can often be triaged over the phone, so you don't need to evaluate all those people in person. But remember who you do need to consider seeing in person. Consider different risk factors when assessing nausea. Some of those patients, again, you can treat sort of over the phone. You can talk with the nurse and just schedule some new meds. But there may be times when you do want to see those people in person. And so vital sign abnormalities, change in mental status, new symptoms, you should go see them at the bedside. And then remember, melatonin or trazodone are your friends in the hospital for sleep. And that's what I have for you this morning. Thanks so much. I'm happy to take any questions, and otherwise we'll have the slides posted for you.
Thank you so much.
Thanks, Gaby.
Thanks so much, Gaby. That was awesome.
Great. Let me stop sharing. There we go. Cool.
Okay, awesome. Thank you so much.
Thank you. All right, Emily, we'll talk soon, okay?
Okay, bye.
Okay, bye.